sounds like there are a series of things that we utilize to individualize treatment for our patients, both in the upfront setting and in the second line or third line setting, looking at patient factors and disease factors as well. There's one other treatment for chronic myeloid leukemia that we have yet to discuss, and that's omacetaxine. Ellie, I was wondering if you could discuss that agent for us.
So omacetaxine is not a tyrosine kinase inhibitor. It's a protein synthesis inhibitor. It's an old drug that has shown activity in myeloid disorders. Then the drug was brought back with a different formulation into the clinic. Studies were done in patients who failed multiple TKI, 359 mutation as well. In the chronic phase, we've seen around 10% CCYR. In advanced stage disease, less responses, obviously, with shorter duration of response. The problem with the drug is it's given sub-Q twice a day for 14 days and for induction, and once you respond, you go to maintenance. It was cumbersome because when the drug was approved, patients have to come to the hospital, spend 14 days. You know, in August last year, the FDA did approve the change of the label where patient can get drug at home. So to be honest, in the era of all these TKIs available, I see minimal place for omacetaxine. However, if you failed everything and somebody in advanced stage disease, you may want to use it in combination eventually with TKIs and hope for the best. I think the drug needs to be optimized. The dose, it's not the best dose. Do we need 14 days where we can use it at a lower dose? I don't think we need 14 days. That needs to be optimized. I keep in my practice omacetaxine as like for patients in whom all TKIs have failed, and inpatient eventually in the blast phase disease where chemotherapy may be tough for them. You want to give them these alternative. This is where I have the drug in my practice.
Stu, what has been your experience?
Yeah, we've used it in patients with blast crisis who've failed a TKI, and it is fairly myelosuppressive. So when you give the 14-day regimen, the patient's blood counts will fall fairly dramatically. So I have some caution with it. It's not a drug that I'm going to be using very often, but once again, if the patient's failed TKIs, they're not a transplant candidate, and I'm trying to sort of give them low-dose therapy, maybe at home now, to sort of slow their disease down, knowing that most likely, unfortunately, the response rate is going to be fairly low. And so it's more of a palliative maneuver, which is very different than we think of with the TKIs, where we're trying to get them in remission. And this is more a palliative end-stage approach.
It's also an agent that we think most practitioners, whether at an academic center or in a community practice, will have very limited experience with. I think between the 5 of us, we have only couples and handfuls of patients that we've treated with the agent each.
Yeah, but I think we'd all agree that, you know, there is a need. We all have some patients who, for one reason or another, are either resistant or intolerant or not candidates for one of the 5 approved therapies. And I think there's definitely, you know, room in the field for more kinase inhibitors, as crazy as that sounds. I mean, we have an embarrassment of riches relative to many other diseases, but I certainly have a few patients who, you know, the longer this is, I guess, you know, part of what comes along with, you know, effectively managing a disease for longer and longer is that if there are some late occurring toxicities, those are going to catch up with us, and we're going to need other options.
You know, we were spoiled with these TKIs, and we were spoiled with CCYR, MMR, and all these fancy milestones. But to be honest, in somebody who failed multiple TKIs, these milestones are unrealistic. So therefore, when you get to omacetaxine after failing 5 TKIs, you cannot expect to have a CCYR rate of 50%. So I think these patients who have advanced stage disease, have them CHR and conserve certain quality of life may not be a bad idea.